His medical history, so no history chronic disease, surgical procedure, or food allergies. He underwent a colonoscopy 5 years ago without any abnormal findings. His family had no history of malignant disease related to the stomach or the colon. On clinical examination, it's mostly normal. He has no abnormal rash, he has no joint pain, his vital sign is within normal. His thyroid gland is not enlarged, and rectal examination show no blood or any other abnormalities. On the lab test, there's no significant abnormalities. Also on ultrasound, we only see that he got grade 1 fatty liver and a gallbladder. His CRP was also within normal range. We do some stool tests, but there's nothing abnormal. On endoscopy, we saw that the patient has short segment Barrett's esophagus and chronic gastritis with negative helicobacter. And for colonoscopy, he has just some very small polyps which has been resected. So which could be the patient could be caused by IBS, or particularly IBSD when his stool is in the form of type 6 or 7. But also we also consider about SIBO, so we perform a hydrogen breath test for the patient, and the hydrogen has increased with 3 other time stamps. The other test results, we saw that the thyroid hormone was within no range. His stool microscopy is negative for fecal fat. He has low vitamin D and it's low zinc. So we want to focus on 3 questions for Dr. Chua. So when do we should consider SIBO in IBSD patient, and in this patient after diagnosis by maybe hydrogen breath test, which additional tests are recommended for the patient, and what is the treatment strategy for this patient? Thank you.
Thank you, Dr. Bin, for a very nice case presentation. When to consider SIBO in IBSD patient, I think it varies according to places, where depending on the availability. How about in Vietnam, Professor Du, is it readily available the test to do a SIBO?
Very few institutes can do that.
Right. So I think that determines, when to redo that. Okay. So if you look into the guidelines, of course, a lot of guidelines like American guidelines, North American consensus, Asian guidelines, and even European. A lot of it is like, conditional recommendation. Worthwhile to do it if it's available. How about in other centers like Japan?
In Japan, for example, the breast test is not covered the insurance. So we have to do is the first, the X-ray or CT scan, evaluate the structural diseases. After that, we do introduce the patient to the specific technique for the university. It's the operation period.
Right. How about China, Tao Bai?
I think when to consider SIBO in IBSD patient, I will always consider SIBO in IBSD patients because the high prevalence in IBSD patient that is unidentifiable. So about the accessible of the instruments, it starts to widespread these years, I think. But in the past, I will judge the patient, diagnose the patient, or whether he has SIBO with the symptoms. Sometimes gas-related symptoms very severe, or hypothermic-induced symptoms. I can consider SIBO, and we can get rifaximin, and it is it can be used to treat IBS-D and as for patients with this clinical steroids such as drugs.
Right. I guess China is widely available, the breath test machine and all, they can easily consider. The beauty of it is like non-invasive test. Of course, if the gold standard is a small bowel aspirate, then we might be more hesitant to do it. But if like the alternative is available, of course, it's not the most optimal test. At least it's not invasive, can be easily done. Manas, how about yourself?
So, SIBO definitely in IBS-D subpopulation, you have to, before stamping it IBS-D or functional something, in literature it is evident that we have to look for SIBO, we have to look for bile acetaria. Significant population of IBS-D, they have bile acetaria, they have SIBO. And SIBO we can consider in IBS-D population, they are more predictive in group like those who are more diabetic, those who are obesity, those who have history of intestinal surgeries. And in those subgroups, definitely we consider SIBO. We have to more suspicious, you have to test them. And in India, the test is available in a lot of centers, but of course not in second tier, third tier city kind of thing, clinic kind of thing. And rifaximin is readily available everywhere. When you have to suspect in that clinical scenario, you have to suspect SIBO. If it is available blood test or jejunal aspirate, you can go ahead with it. Not available, we can try with a trial of rifaximin for 14 days, and you can definitely see the symptom improvement and all those things.
In other words, what Manas has been trying to say is like we have to look at the risk factors as well. For example, in patients with history of surgeries, abdominal surgery, pelvic surgery, they are more at risk. Diabetes patient or on PPIs also. Professor Linda, do you have anything to add?
Well, in terms of gold standard, truly there is not a gold standard for diagnosing SIBO because the breath test is a surrogate marker, and really the small bowel aspirate is the gold standard, but there's challenges with that. There's new technology coming out where there's these capsules that you can swallow and it can then aspirate the small intestinal fluid. So I think that will evolve over time. And I think whether it's SIBO or IBS diarrhea and to do breath test or not really depends on the resources that you have, right? So if you don't have access to breath testing and their symptoms are classic for IBS diarrhea, it may be more economical to do a trial of rifaximin than to do a breath test. And I think I typically reserve the breath test for patients who do not respond to therapy. And as Kevin said, there's a high placebo response. So oftentimes with rifaximin, if you diagnose them with SIBO and you give them rifaximin, they'll tell you they feel better on the therapy, but as soon as they stop the medication, their symptoms come back. So I'm always very careful about diagnosing SIBO because patients will then, at least in the US, they become very attached to their diagnosis and then they don't want to give it up.
I think it's very nicely summed up, what is the SIBO and what strategy to do to suspect SIBO and what tests or when to do it, which I will also summarize in my slides later on. Next, about in SIBO patient, which additional tests are recommended? I suppose I will also cover a bit in the slides. And generally in SIBO, a lot of time if you are looking at DGBI and overlap or pathophysiology that's related to SIBO, most of the time they are not so severe that cause malabsorption, whereby in the past, patients typically started to diagnose SIBO in the patients with a small bowel resection, then they have this stasis and cause SIBO. Those are the patients they first describe the presence of SIBO And those are the patient has a lot of malabsorptions in terms of many nutrition or so. Of course, you also want to do other tests to look for the precipitating factors, for example, diabetes or even thyroid. Sometimes you even want to look for any slow transit, GI as well. In terms of treatment strategy for this patient, I'll cover in my slides as well, I suppose. Is there any other question before I start my short mini lecture? Minutes. All right. So very briefly, SIBO is about 0 to 22% depending on the type of the test, and more in patients with risk factors. For example, elderly patient can be up to, some reports up to 14.5 to 56%. So, what prevents SIBO? What are the protective mechanisms of our body to prevent SIBO postulated by all these gastric acids? That could, prevent the ingested bacteria from fermentation. The pancreatic enzyme, the bile acids as well, that protects our, small bowel bacteria, from overwhelming and all. Then intestinal motor activity, for example, those with slow transit for dysmotility that cause stasis, that could cause overgrowth of the small bowels. Intestinal mucosa integrity, that has some immune system that can protect and prevent and maintain the stable microbiota in the small bowel. Of course, our ileocecal valve, if it's patent, can prevent the migration of the colonic microbiota back to the small bowels and cause overgrowth of the small bowel. If there's any disruption in any of the factors that could predispose patient to small intestinal bacterial overgrowth. So these are the conditions, examples that is associated with SIBO. Among them, IBS that could have some dysmotility or motility problems, and that as described. So in terms of the symptoms-wise, bacterial fermentation, carbohydrate fermentation, it could cause all these flatulence, abdominal pain, distension, diarrhea, and even there will be problems with the bowel acid conjugation that could cause diarrhea, competition of the bacteria with the body nutrients, and also protein loss, inflammation, microinflammation, and increased permeability, and of course the more severe type will cause malnutrition as well. In terms of diagnostic challenges, of course the gold standard is small bowel aspirate, but there are so many challenges in terms of small bowel aspirate. You can do either a deep duodenal or jejunal aspirate. The definition at the moment is if you can do 10 to the power of 5 the colony form unit, or 10 to the power of 3 of CFU if coliforms are present, or the quantitative culture of the upper gut aspirate. The limitation, as also mentioned earlier on, problem is invasive. Of course, doing OGD, deep duodenal or proximal jejunal intubation is not too difficult, but it's still considered as invasive. And other than that, the cost per se and the technique of aseptic collection of small bowel aspirates can be a challenge. That might be a contaminate from your mucosa, oral mucosa, sample handling, and cultures is also a challenge itself for the microbiologists. Of course, as mentioned, invasive and expensive, and among all, it's not all can be aspirate and can be cultured, because that's as far we can go, proximal, jejunal. How about the distal gut, which we cannot culture? Could we miss that as well? So small bowel aspirate, although it's the gold standard, still have a lot of limitation. Therefore, quantitative measurement of the breath hydrogen and methane, which is relatively not inexpensive, non-invasive, and easy to be done, can be recommended as an alternative test, which is comparable to culture. So meta-analysis has summed up and recommend, and shows that glucose hydrogen breath test has a better sensitivity and specificity compared to lactulose hydrogen breath test. Both of them are currently the most commonly used to do a hydrogen and methane breath test. Limitation per se, glucose, although is preferred, but also have problems because glucose is readily absorbed proximally. So by the end of the distal small bowel, is completely absorbed already. It cannot be fermented if there's presence of small bowel, small bacteria. Therefore, could be low sensitivity detecting distal SIBO. On the other hand, lactulose has false positive rate especially because lactulose in patients with a rapid small bowel transit, by the time, although we put it as 90 minutes, we complete the test, but sometimes within 90 minutes, there's also a presence of positive hydrogen. Whether is it because the fermentation in the colonic, in a rapid transit GI patient, or is it truly a SIBO? So that can be a question. In the North American consensus, they recommend that hydrogen elevation of 20 parts per million by 90 minutes during the glucose or hydrogen breath test for SIBO is considered as positive. In contrast, the Asia Pacific consensus suggested that more than 12 ppm by 90 minutes from baseline is considered as positive. Both of them agree that methane positive is important, and as cause if anything that is presence of 10 parts per million is considered as positive at any time point. We have submitted for publication, but it's still under review. So to compare, if we use 12 or 20 ppm by the American as well as the Asian guidelines consensus cutoff, it shows that of course when we use the lower cutoff, the higher proportion of SIBO can be identified, 44.4% versus 37.8%. And when we look into those with positive SIBO by the Asian cutoff, they are also associated with greater IBS symptom severity. So, in other words, using a lower cutoff, we can identify more patients with SIBO and at the same time identify more patients with severe IBS symptoms as well. So in the North American consensus and the ECG guideline, they recommend that they use a glucose or lactulose hydrogen breath test and in patients with IBS. But of course, you see conventional recommendation very low level of evidence. And they also suggested that in symptomatic patients with suspected motility disorder, as recommended by Professor Manas, as well as those with risk factor, suggested to consider SIBO test. Use of patients with previous immunosurgery with typical symptoms should be recommended as well. So in the meta-analysis in the AGG journal, they published that SIBO is associated with IBS is increased compared to controls with an odd ratio of 3.7. And among them, those with IBSD are more commonly associated with SIBO compared with those with constipation predominant IBS. We have also published a paper before, and we found that among all the FGID, among all the DGDI, when we compare, only IBS with diarrhea predominant subtypes is associated with SIBO and higher proportion with SIBO compared to control, 24% versus 10%. And we have also published another paper that shows that those with IBS, with SIBO, they are associated, more of them, those with IBS with SIBO, has higher symptom severity as measured by IBS SSS score, that's more than 300. So 36% versus those without SIBO, 16%. And we have also asked another question, whether is it because of the, more fermentation, more positive breath test that is associated with symptoms, but are they all the same? So meaning that, is it like positive with glucose, is it the same as positive as lactose and fructose hydrogen breath test? So we found that actually in those with SIBO only associated with severe IBS symptoms rather than those with positive for lactose and fructose. And on multivariate analysis, we found that SIBO and depression were independently associated with severe IBS. So testing for methane also recommended during the GHBT and LHBT test in patients with symptomatic constipation, especially those suspected slow transit constipation. Again, the level of evidence is not very strong. Meta-analysis shows that constipation patient was associated with methane positive with an odd ratio of 3.51 compared to control. In terms of management, the question that asked by Dr. Lee, alright, so how do we manage? If possible, we will want to include the following. Treatment of the predisposing condition, for example, diabetic patients, you will want to treat the diabetic better. Those with transit problem, you may want to consider prokinetics at the same time, appropriate antibiotics, and also correction of the nutrition deficiency is present. Okay, in this Asian guidelines, Asian consensus, so they recommended that rifaximin is the recommended one. If presence of response, just follow up on it. If no response, you may want to reconsider the reassessment with graph test and retreat if possible. So best evidence at the moment is rifaximin. Meta-analysis shows that the treatment efficacy, frequency of eradication is up to 72.9%. Okay, the American guidelines also recommended that other systemic antibiotic may be considered. So recurrence of SIBO is common, in a study that follow up, in an Italian study, 12.6%, 27.5% and 43.7% in 3, 6, and 9 months follow up. And the studies also shows that retreatment with rifaximin was found to be effective as well. So this landmark study in NJN found that rifaximin therapy in IBS without constipation. Of course, the efficacy is statistical significance, but if you scrutinize it, the improvement compared to placebo is only about 10%. Is it good enough? By improvement by 10%. Of course, we hope for more. So another paper, I think they use it from the same cohort that they follow up the patient. For those that has breath test, those that positive lactulose breath test, in other words, we probably can label that as SIBO patient. And they treated with rifaximin, compare those with negative lactulose breath test on baseline. You see the improvement is quite remarkable, 59.7% versus 25.8%. In other words, the improvement is 30% in compared to those in the NEJM paper whereby they just treat everyone with IBS without constipation. This group is they treat it with baseline positive lactulose. Then you can see the remarkable improvement with rifaximin therapy compared to placebo. So in summary, this is my next slide. Okay, in patient with DGVI, identify eye symptoms, risk factors suggested of SIBO, then we test accordingly. Non-invasive tests, if it's available, will be good. Management should treat the fetal skin condition, start suitable antibiotics, and correct any malnutrition. With that, I would like to thank you for your attention.